Welcome back, doctors. On to our next lecture, which is anorectal. Again, Dr. Singer.
Okay, thank you. So the next segment will be anorectal surgery. Here are my disclosures. Okay, here's the list of topics we will be covering in this section. So we'll start with anal dysplasia and some STDs. So the first case, anal squamous cell carcinoma can be caused by which of the following viruses? CMV, HPV, HSV, rotavirus, adenovirus. Go ahead and enter your answers. Okay, great. Just about everybody. HPV, human papillomavirus, can cause squamous cell carcinoma of the anus. And we'll talk a bit about that. So that discussion starts really with warts, anal condyloma, which, as you know, are related to HPV. So by far, HPV is the most common sexually transmitted disease. In some populations, upwards of 80% of people will have HPV living in or on them. Known risk factors include, like with all STDs, multiple sexual partners, and for anal HPV, of course, anal intercourse, and immunosuppression, most commonly HIV. And it's important to note that that includes HIV, not just AIDS. This is certainly not an AIDS-defining illness. Topical treatments include Aldara, podophyllin. Those are the two most common. Also chloroacetic acid can be used for small burden of disease when patients have a small number of warts on the perianal skin. These are not good treatments for intraanal warts because you simply can't apply that. Patients that have a large burden of disease, even including the patient in this photo, this is not going to be a great way to go. This requires usually somebody else to apply the medication. These are irritating to the skin. You don't want to just slather them on. They'll get a lot of skin irritation. They have to be applied very specifically. So for practical reasons, this is often not a great choice, but an option. These drugs are immunomodulators in some way. It's not entirely clear why they make warts go away, but they somehow stimulate the patient's immune system to resolve the warts. Patients that have intraanal disease or significant perianal disease usually are best treated with surgical treatment, which includes excision and fulguration or cautery of the sites in an attempt to destroy any HPV that's living in that tissue. Now, anal intraepithelial neoplasia or anal dysplasia, there's been sort of a renewed interest in anal dysplasia of late. Because it's becoming more the standard of care to screen patients for anal dysplasia. This follows really the great success story of screening women for cervical dysplasia and cancer. And so, as you know, massive screening of women in the United States has finally led to a significant decrease in the incidence of cervical cancer for many years now. That's really the same pathologic process that occurs with anal cancer. Along the spectrum of HPV to anal dysplasia to anal cancer, it's really the same process as in the cervix. And so the thought is, if you screen high-risk individuals for anal cancer or dysplasia with anal pap, perhaps we can intervene at the dysplasia time point and prevent anal cancer. To be clear, this strategy has not yet been shown to decrease the incidence of cancer or decrease the death rate of anal cancer, but this is why there's sort of a renewed interest, is that many practitioners are now screening patients. The patients being screened are those at high risk, so primarily HIV patients, men who have sex with men, or those who are already known to have anal dysplasia because they have symptomatic lesions. So anal dysplasia, or AIN, for a long time has been referred to as Bowen's disease, most commonly now referred to, though, as AIN. This is caused by any of the HPV virotypes, and there's somewhere close to 100, but the ones that are most associated with cancers are 16 and 18. Those are sort of the bad actors of the group. But again, it's not limited to those. For that reason, virotyping is not usually done. Most you basically treat all of them the same because any of them can cause dysplasia or cancer. All of the lesions should be either resected or ablated, cauterized, destroyed by some method, whether it's with cautery or laser or infrared coagulation. People use different techniques, but it's really just a form of local tissue destruction. And these patients should be followed frequently, looking for recurrences or progression. Now, if they do progress to anal cell cancer, then the treatment is fairly clear-cut. Anal squamous cell cancers are treated with the NIGRO protocol, chemoradiation, including 5-FU, mitomycin, and radiation therapy. Fortunately, this is curative. Most patients, 80% or better, will have a complete response. And radical surgery, which is usually going to be an APR, is left reserved only for patients with persistent or recurrent disease. So it's still a little bit of a story in evolution about what to do with anal dysplasia. People are undergoing high-resolution anoscopy to follow and carefully watch these patients. It's not yet clear how that story will end, but if they do have anal cancer, it is pretty clear. They get chemoradiation, reserving APR for those with persistent or recurrent disease. Okay, now we'll talk a bit about rectal cancer. I realize we've already done the colon section, but rectal cancer is included more in the anorectal section. This is a case of a 70-year-old man diagnosed with a T3N1 M0 rectal cancer, 10 centimeters from the anal verge. The initial treatment approach is A, low anterior resection, B, neoadjuvant chemoradiation, C, neoadjuvant chemotherapy only, D, abdominal perineal resection, E, local excision. So a T3N1 rectal cancer. Okay, great. So the treatment for this would be neoadjuvant chemoradiation therapy. This would be then followed by low anterior resection. Rectal cancer, we'll get to it in a second. Malignant rectal polyps. So patients who have symptomatic lesions, usually presenting as bleeding, or those identified in screening colonoscopy, will often have rectal polyps. And then it becomes a question of who's a good candidate for transanal excision. This is different than colon polyps, of course, because we can't get to those in a transanal fashion. But rectal polyps, we can, for many of them, have good access by conventional transanal surgery or TEM, TAMIS, some other newer techniques. So how do you decide what kinds of polyps or cancers can be excised transanally? So selection criteria. Polyps that are smaller than 3 centimeters is a usual guideline. This, of course, depends in part on the skill of the surgeon, but also larger lesions may have a higher malignant potential. So smaller lesions, less than a third of the diameter. You should be able to perform a full thickness excision with margins. So you don't want to just do sort of a polypectomy. You want to do an actual full thickness excision. On the biopsies, you want to make sure there's no lymphovascular invasion. This would give you concern for regional metastases, and it should be a well-differentiated tumor, not an undifferentiated or poorly differentiated tumor. So those types of lesions can be excised transanally, as you see here, either by conventional transanal surgery, it's a regular old-fashioned full-thickness excision, or if you prefer using newer techniques like TEM. I'll just back up for a minute. That applies mostly to polyps. Rectal cancers can be excised transanally, but that should be reserved really only for T1, the earliest stage tumors. Not all tumors should be excised transanally just because they're small and low, only T1 tumors. Beyond that, the risk of regional lymph nodes becomes too high, and most people would not recommend that. Okay, staging for rectal tumors. These tumors need to be staged in a variety of ways. The depth of penetration, so the T stage, can be evaluated either by ultrasound or MRI. MRI probably becoming more popular, but both of these are acceptable choices. The regional lymph nodes should be evaluated, again, either by ultrasound or MRI. And then workup for metastatic disease should be done with CT scan of the chest, abdomen, and pelvis. So these patients need multiple staging exams. Now, patients who have T3 or T4 or N positive disease should be treated with neoadjuvant chemotherapy and radiation therapy. And so that's going to be typically 5-FU plus 50 gray of radiation. And this is done for a couple of reasons. Tumor regression, so radiation definitely shrinks these tumors. It improves the resectability. You can imagine big tumors are more difficult to resect, and you can shrink up the tumor with the radiation therapy. This results in a higher rate of sphincter preservation. Bulky tumors in the mid or distal rectum create a difficult problem to do a low anterior resection and result in a higher rate of APR. Shrinking them down results in a higher rate of sphincter preservation. Now, some patients, and somebody was asking about this after the last session, some patients will have a complete pathologic response. So some of these tumors will completely regress. But that's in the range of 10 or 20%. And it's not predictable. We don't yet know with any amount of reliability who's going to have a complete pathologic response. So for that reason, patients who have rectal cancer and get neoadjuvant radiation and have a complete response should still be recommended for radical excision at the current time, for sure in the board exam. There are some centers in the world who are advocating a watch and wait approach with very intense follow-up of proctoscopy and ultrasound and biopsies and all that, and that might be suitable in some scenarios or in some protocols. But the standard of care in the United States clearly remains neoadjuvant chemoradiation followed by radical excision. Now, that might be either a low anterior resection or abdominal perineal resection. In either case, the patient should undergo TME, total mesorectal excision. Post-operatively, they should undergo adjuvant chemotherapy, again with FOLFOX or FOLFIRI. Just a word about TME. Whether you're doing the LAR or APR, it's important to resect, of course, not just the rectum, but the mesorectal envelope, because we know that's where the extratumoral deposits will be, and that's where the lymph node package will be. So performing total mesorectal excision is really a critical component of treating rectal cancer. On the exam, you are not likely to be asked whether a patient can undergo LAR versus APR if the tumor is at 2 centimeters or 4 centimeters, because that depends on a lot of things, including the experience and technical skill of the surgeon, and that's not what's really being examined. It's critical to know that patients are treated with chemoradiation followed by total mesorectal excision. That's really what you need to understand, not so much who gets an LAR versus APR. Now, clearly, if it's a very distal tumor, if there's invasion of the sphincter, if they're already incontinent, any of these things, they should get an APR, no question. But don't worry so much about if it's at 2 centimeters, if it's at 4. That kind of difference is too subtle for this exam. Okay, moving on to benign anorectal problems, anal fissure. Fissure, of course, a very common problem. Fissure is a tear or a chronic open wound, generally associated with constipation, but also diarrhea. Patients have a hard stool and it creates a small tear. Most times that will heal, but oftentimes it does not and can become a chronic situation. That fissure creates pain, of course, and inflammation, and leads to sphincter spasm. And it is the spasm or hypertonicity of the internal sphincter that propagates this problem. The fissure will not heal so long as the sphincter is in spasm. So the treatments are directed at sphincter relaxation. Medical management always starts with bowel management, so fiber, treating constipation, laxatives as needed, all that stuff. Medical management of either nitroglycerin or calcium channel blocker like nifedipine ointments can be used. Bowel management and calcium channel blockers, or nitro, are approximately 50% effective at long-term cure. Alternatively, you can offer a Botox injection to relax the sphincter. This is approximately 60% effective at long-term cure. Or surgical treatment which would be lateral internal sphincterotomy. So a partial sphincterotomy, internal sphincterotomy, and this is about 95% effective. So clearly the most effective. The main complication that we worry about, of course, is incontinence. Dividing some of the sphincter is going to result in incontinence in some patients. So this actually comes up on the test, and you are likely to see questions like, a 21-year-old healthy man has a fissure, he's failed, Botox, he's failed nifedipine. Clearly that guy gets a sphincterotomy, everybody's happy. But also you see questions like an 80-year-old nursing home lady with a patulous anus and chronic diarrhea has a fissure. No way does she ever get a sphincterotomy. So if you have any concern of incontinence, chronic diarrhea, neuromuscular problems, debilitated, had 10 vaginal deliveries, any concern about incontinence, do not do a sphincterotomy. So normal patients, it's the best treatment, no question. But any concern, don't do sphincterotomy. That's usually the kind of question that they'll ask regarding anal fissure. If you're going to do it, just to remind ourselves, you can do it in an open fashion. You make an incision, identify the internal sphincter, which looks white, and do a partial sphincterotomy. Or you can do it in a closed fashion and put a finger in the anus and insert a scalpel into the intersphincteric space and cut some of the internal sphincter that way. Either way, acceptable, same results. Okay, moving on to abscess and fistula. So anal rectal abscess and fistula most often occur for nonspecific reasons. Cryptoglandular abscess. Basically, these are otherwise healthy patients. There's a long list of specific reasons patients can get abscess or fistula. The ones you should definitely know, of course, are Crohn's, so that's common. In this other list, you should be familiar with TB, unusual infections, systemic malignancies like lymphoma and leukemia, all these kinds of things, radiation-related issues. But by far, most often, abscess and fistula are related to cryptoglandular disease. Commonly on the exam, there will be questions about patients presenting with an abscess, and almost always the answer is drain it. One sort of specific question that is not uncommon, patients who present with a day or two of pain and there's no bleeding or drainage and their exam is normal. Intersphincteric abscess, I'll back up. Intersphincteric abscess may often present with no physical findings in the emergency room or in your office because the abscess is nicely enveloped in the sphincter. So you don't see a big red hard mass like you do with the ischioanal abscess. And these people should go, they need to be drained, so doing an EUA, if you can do it in the office, or an EUA to drain it. But that comes up on the exam. Draining the abscess and observing for healing versus fistula. Sometimes the question comes up, if you identify an abscess and a fistula at that time, is it appropriate to do a fistulotomy? And the answer is yes. If they're a good candidate for a fistulotomy, you can do it at the initial presentation. So if there's a small amount of sphincter muscle involved, go ahead and do a fistulotomy and you're done. But if you have any concern about incontinence, draining the abscess and leaving it alone is the appropriate answer. So if the patient should have a fistula, there's a lot of choices. Fistulotomy, of course, is the operation that we like to do because it works very well, 95% or better. It's fast, it's easy, you don't need any special equipment. But of course, incontinence is the real concern. You're not likely to be asked questions about how much exactly of the sphincter can you divide with a fistulotomy. Again, it's more about patient selection. A woman with an anterior fistula, don't divide that. A woman who's had multiple vaginal deliveries. Patients with chronic diarrhea. Anybody who you have any concern about incontinence, be very cautious to do a fistulotomy on them. But if the patient is a 20-year-old athletic guy, otherwise normal, that's a great candidate for a fistulotomy. Now, if you're not going to do a fistulotomy, then you have a variety of options to treat the fistula. A seton can be used either like this, a loose draining seton. That's a good option when they present with an abscess. You can drain the abscess and fistula and come back to do a definitive procedure. You may choose a cutting seton, which is essentially like doing a slow fistulotomy. That would be an option. Fistula plugs are available, endorectal advancement flap. is a good option. These are non-cutting operations. In other words, you're not dividing any of the sphincter fibers. So in patients you have concern for incontinence, flap, plug, or the newest of these, the lift procedure. Not super common yet, but any of these non-fistulotomy options would be reasonable. Here you see just some photos of fistulotomy. You probe the tract, identify any side branches or injuring pus, and simply lay open the tract. You can do it with or without marsupialization of the skin edges. It doesn't really matter too much for this purpose. Okay, let's talk about hemorrhoids a little bit. So hemorrhoids, as you know, come in two flavors, internal and external. Internal are often referred to by the grade. The grade, to remind you, refers to the amount of prolapse. It doesn't sort of stratify the symptoms like pain or bleeding, but it really only refers to prolapse. So non-prolapsing, prolapsing that reduce spontaneously, prolapsing that require manual reduction, or irreducible. Many patients will have combined, both internal and external. Many women who are pregnant, especially if they undergo vaginal delivery and they're laboring, will have significant worsening of their hemorrhoid symptoms. And sometimes you'll see questions about rectal varices, which are not the same as hemorrhoids and should be treated differently, and we'll, I think, get to that. Yes. Somebody's phone is ringing. So B and D are external hemorrhoids. C is an internal hemorrhoid. The main difference, of course, between external and internal, the internal hemorrhoids originate above the dentate line, and the external hemorrhoids originate below the dentate line. The external hemorrhoids will be covered in skin, and because they're below the dentate line are quite sensitive. The internals above and not as sensitive, which allows us to do office procedures that we'll talk about in a minute. The A and E are sort of the same, but in cross-section. We're seeing a sagittal image, and so you're just kind of seeing the internal and external hemorrhoids in cross-section. So I guess D and E on this picture are really the same structure. All right? Now, everybody should start with dietary medical therapy. So always regulate the bowel habit, whether they have constipation or diarrhea. That needs to be addressed. Fiber supplements, high fiber diet, stool softeners as needed, more water intake. Everybody gets that. For internal hemorrhoids, because they originate above the dentate line and are relatively insensate, office-based treatments are a good option. Most commonly rubber band ligation, also infrared coagulation. And just to remind ourselves in the cartoon here, rubber band ligation involves taking one or two bands and placing it at the sort of base of the hemorrhoid. This is a technique of fixation, as is IR coagulation. You're putting the band at the mucosa, and it creates a little inflammatory response and a scar, and it's the scar that keeps the hemorrhoid fixed high in the anal canal so it does not prolapse. We tend to conceptualize this as sort of a tying off of the hemorrhoid, and so it becomes necrotic and falls out. Patients often think of it, but it's not exactly that. You're creating a scar to prevent prolapse. IR coagulation does the same. Injection, sclerotherapy, you're just making a scar to prevent prolapse. This is extremely safe and easy to do. Patients who fail office procedures or have very advanced disease may undergo operative treatment. So operative hemorrhoidectomy, sort of the gold standard, the old-fashioned excision of internal and or external hemorrhoids. And that operation is definitive and safe, and most patients will do well. Of course, there's considerable post-op pain, which is what scares patients away from this operation. Thrombosed external hemorrhoid is a common scenario, and there's often questions about this on exam. So patients who may or may not have a history of hemorrhoid disease will present with 1 or 2 days of a very painful lump, and that history is generally either going to be an abscess or a thrombosed hemorrhoid, one of those two things. And usually you can tell by a simple office exam. Thrombosed hemorrhoid will be in that location, it'll look blue or purple, and it'll be exquisitely tender. If they have mild symptoms or it's been a few days, more than 2 or 3 days, they're best managed with bowel management, pain medicine, sitz baths. If it's acutely, meaning in the first day or 2 or 3, they do well with excision of their thrombosed hemorrhoid. The best answer is to excise the hemorrhoid, not just incise it. Because if you open the skin and evacuate the clot, they do get relief, but they're at risk of reaccumulation of the thrombus. So if you can excise it in the office, that's the best. Here you see a illustration of excisional hemorrhoidectomy of the internal and external components. Basically excision and suturing closed of the defect. Now, because that operation is so painful, there are newer alternatives, including stapled hemorrhoidopexy, which you see here. This operation makes use of a modified circular stapler and basically does a few things. It returns the hemorrhoids high into the anal canal. It excises a circular strip of mucosa and submucosa, again to suspend or pexy the hemorrhoids high in the anal canal. It does not perform complete excision of the internal hemorrhoids. It only suspends them in the anal canal. It's also thought to disrupt the blood supply with the ring of staples. What it does not do is directly address the external hemorrhoids. That staple line is well above the dentate line, so there's less pain than hemorrhoidectomy, but it does not address the external hemorrhoids. If you were to be asked a question on this kind of thing, it's most likely, again, not about the technical aspects, but about patient selection. Patients with internal hemorrhoid and minimal external hemorrhoid disease are good candidates for this. It provides good control of their internal hemorrhoids with less pain. If they have big, bulky, bleeding, itchy external hemorrhoids, this is not the best choice because it will not treat external hemorrhoids. Okay, a few things on fecal incontinence. So fecal incontinence is related to several different things, most commonly related to obstetric injuries. Somewhere around 1/3 of vaginal deliveries result in some degree of tearing of the sphincter. Most of these women, of course, are not symptomatic, but it's a very common issue. If they do become symptomatic, it's oftentimes years or decades after their delivery. So this is this kind of thing is sometimes on the questions. A patient presents at 60 years old with various degree of fecal incontinence, and it's important to remember what her obstetric history is because that's likely going to be the cause. Other causes, rectal prolapse. Patients who have rectal prolapse, every time the prolapse goes through the sphincter, they get a stretching of their sphincter, and over time that can certainly cause incontinence. Pelvic floor weakening with age. Injury to the pudendal nerves. This is also an obstetric injury. We tend to think that vaginal delivery is really the only cause of fecal incontinence, but it's not. Even gestation is associated with fecal incontinence with C-section, because for 9 or 10 months the baby is sitting right on the pudendal nerves, and so they can get a pudendal neuropathy even if they don't have a vaginal delivery. So women, even with C-sections, are at risk of fecal incontinence. Functional abnormalities can contribute to fecal incontinence. Impaired sensation, why that happens, I don't really know. Nobody is really clear on that. But if people cannot adequately sense the full rectum, sometimes they have leakage. Fecal impaction with overflow incontinence. So sometimes incontinence is the presenting complaint, but what they really have is constipation with some overflow. So they need a bowel management plan. Important to pay attention to stool consistency. Patients with liquid stool, mushy stool are going to have a more difficult time retaining their stool than patients with good bulky stool. So everybody gets fiber and lots of it. And also psychological factors. The incidence of fecal incontinence in inpatient psych wards is extremely high. It's not always clear how their psychosis relates to their bowel function, but it does. And so you have to address depression, anxiety, and all that, even if not overt psychoses. Treatment of incontinence, supportive measures like lifestyle changes. You have to remind patients, leave the bathroom, or go to the bathroom before you leave the house, simple things like that. It makes a big difference. Pharmacologic therapy with bulking agents like fiber, constipating agents like Imodium or Lamodal can be very effective and even safe in the long term. Biofeedback therapy, which is part of pelvic floor therapy, essentially muscle retraining, also teaching patients to sort of relearn the sensation of a full rectum and strengthen their pelvic floor muscles. This can be very effective. Using things like plugs and bulking agents is a possibility. or surgery. Patients have essentially two common choices. One would be sacral nerve stimulation, which has become very popular in the United States, or sphincter reconstruction. In general, questions are going to focus around the anatomy of the sphincter, so they will tell you that the patient has an ultrasound with a big giant sphincter defect. That's somebody to consider sphincteroplasty. Or it'll be a man with no sphincter injury. That's somebody who's a good candidate for sacral nerve stimulation. In truth, people with defects are getting sacral nerve, but again, that's a subtle point, and usually you're going to want to just go with sort of the obvious stuff. People with big defects get a sphincter reconstruction. People with not are good candidates for sacral nerve. Okay, and lastly, rectal prolapse. Here you see a terrific example of a full-thickness rectal prolapse. Notice the concentric circles, commonly mistaken hemorrhoids for prolapse. Just to remind ourselves, hemorrhoids have radial folds like you see here. Prolapse has circular folds. It looks like an ileostomy because it's full-thickness prolapse, and that's the best way to differentiate those two. Rectal prolapse, much more common in women. If you can, do a colonoscopy on these patients to make sure that there's no pathology on the inside. There's a variety of surgical approaches. You can do an abdominal operation or a perineal operation. That's kind of the main decision-making point. If you're doing an abdominal operation, then decide if you're going to do a resection or not. Patients who are significantly constipated and pushing and straining all the time, and that's why they get a prolapse, those people can do well with a sigmoid resection and a rectopexy. If somebody is not constipated, and certainly if they have diarrhea or incontinence, don't do a colon resection because you're going to make that worse. So those patients can get a rectopexy alone. Patients who, if you choose not to do an abdominal operation, you can do a perineal operation. The most common would be a perineal rectosigmoidectomy or an Altmaier. And this is sometimes reserved for old, frail, sick patients who you don't want to do an abdominal operation on. To remind ourselves, the Altmaier perineal proctectomy essentially involves reproducing the prolapse and then incising one layer of the rectum and just sort of pulling out as much as you comfortably can, excising it, and doing a hand-sewn coloanal anastomosis. Resection rectopexy, which you see here, involves sigmoid resection and mobilization of the rectum all the way down to the pelvic floor. It's kind of subtle, but here in the pre-op photo, you see here the intact rectum, and in the post-op photo is this empty space, emphasizing that one of the keys to success of this operation is full mobilization of the rectum all the way down to the pelvic floor. The rectopexy can be performed with sutures, as you see here. It can be performed with mesh. Both are acceptable. Again, the types of mesh and biologic mesh and type of sutures, those are subtle points, not important for this exam. But full mobilization and some sort of pexy are really the key steps. Okay, so that's it for the anorectal section. Do we have questions in the back? That was a question regarding the use of postoperative adjuvant chemotherapy in patients who underwent neoadjuvant chemoradiation therapy. Most often the answer is yes, because you're treating more advanced disease, so they will get additional therapy after surgery.